This is Gas Exchange and Respiratory Disorders Part 4, and we're on cystic fibrosis. Cystic fibrosis is that autosomal recessive trait, which means both parents have to be carriers. They will give half of their children their normal gene and half that recessive cystic fibrosis gene. And so statistically, you end up with 1 out of 4 children having the disorder, 2 out of 4 being, or 50% being carriers, and 1 out of 4 gets the normal gene from each parent and is not a carrier and does not have the order. Now, there's no guarantee that if you have 4 children, that's what you'll have. Every pregnancy has that 1 out of 4 chance of having the disorder. So what cystic fibrosis is it's an exocrine gland dysfunction, so everything that's excreted is thick. So we see problems in the respiratory problems in the bronchi from obstruction, from that thick mucus, that which over time then does some damage. It also makes a perfect medium for germs to grow. So these kids kind of have a chronic pneumonia. They get admitted to the hospital usually with pneumonia for IV antibiotics. That thick secretion is also in the intestines. On a neonate, it can cause that meconium to not pass, and that's our earliest indication. Usually they do the sweat chloride test, but a baby who doesn't pass meconium in 24 hours are going to work up for cystic fibrosis. In the pancreatic ducts, again, everything's so thick, it doesn't get out. It ends up making calcifications in there. So because you're not getting those pancreatic enzymes coming out in they should dump out in the duodenum for metabolizing, particularly fats, breaking down the fats. So those don't get broken down and can't get absorbed, so they get those huge, fatty, stinky stools. And then the bile ducts over time get clogged, and the concretions is what they call it, that, they fill up with what's like concrete, and it does damage to the whole pancreas. They're at high risk for type 1 diabetes. In fact, about half of them sometime in their life will develop that, and then portal hypertension. So the clinical manifestations, pancreatic enzyme deficiency, progressive COPD and respiratory infection, sweat gland dysfunction, and this, a parent might say, they taste salty when I kiss them. Failure to thrive, right, because they're not absorbing normally. Weight loss, even though they have a voracious appetite, and then the high risk for type 1 diabetes. So how do we treat this? With our chest percussion therapy, right, CPT. Most of them have a vest at home, so it's pneumatic. It does it for them, but some we teach the parents to do. Bronchodilator medication to help get that stuff out. We teach them forced expiration, and turn cough, deep breathe, all those things. And then aggressive pulmonary treatments. They're doing these at home. They come into the hospital typically just for the IV antibiotics being added to that. And we're also seeing a lot of kids get a G-tube, so they do continuous feedings at night just to maximize the calories that go through the gut, because they don't absorb very many of the calories. So here's some part of the respiratory treatment. Here's a girl in that pneumatic vest. It's not a great picture, but it shows you that. So those are the respiratory issues. GI, we get those thick secretions that block the ducts, and then you end up with damage to that pancreas, but you're not getting the pancreatic enzymes out. So it's going to impair digestion and absorption. So how do we manage these? Well, every time they eat, we give them pancreatic enzymes. When they're young, we take them, they're a capsule, and we'll dump them out on a spoon with whatever, some formula, or as they get older, some purees. And these kids learn to take pills really early, so by the time they're a few years old, they'll take the pills. We do a high protein, high calorie diet, and there are no limits. These kids eat massive amounts of food and have trouble gaining weight. We're going to treat constipation. They're actually at risk for prolapsed rectum, and if it does happen, that needs to get reduced, put back in place. They need salt, so no dietary restriction, no salt restriction, just high protein, high calorie, as much as we can get in them. And then treat reflux if needed, position them up right after meals. So our goals are to minimize or prevent, if possible, pulmonary complications, to really help them to grow, so adequate nutrition, and then assist them in adapting, because this is every day of their life. They're getting up and doing vest treatments. Every time they eat, they're taking handfuls of medications. Okay, on to apnea, or ALTE is apparent life-threatening event. We used to call this a near SIDS because they didn't die, but they stopped breathing and it was a life-threatening event. So apnea, the definition is stopping breathing more than 20 seconds. ALTE is apnea with color change, muscle loss, so they kind of pass out, then have coughing and gagging with it. So the best thing to do is gentle stimulation. If that doesn't work, then we start giving some breaths. Teach the parents about SIDS prevention, right? Back to sleep. No blankets or anything. They're actually using the, calling it safe to sleep now. So no blankets, no pillows, nothing in there. Train parents in CPR, and many of these children, if they've had a ALTE episode, they'll go home on an apnea monitor. So to prevent SIDS, sleep supine, firm mattress, no pillows, stuffed animals, blankets. Don't sleep with the infant. Parents shouldn't sleep with the infant. It's okay to hold a sleeping infant, but parents shouldn't be sleeping. Smoke exposure, including intrauterine, so before birth, that smoke exposure increases the risk of SIDS, and then after birth, it also increases the risk of SIDS. If a SIDS happen, we've got to support these parents, because they're usually initially treated as if this was an abuse case, and the child just dies in their sleep usually, and no one knows why. And then the parents have lost a child and then are being questioned as if they're suspects. So it's really traumatic. A child who is on a home apnea monitor, we really want parents to use these. They go off all the time, which means the parent's not getting any sleep, but it helps. And it may be that sometimes that alarm kind of stimulates the child and makes them breathe, or sometimes they just go off false alarms, but it's not going to work if it's not put on. Kids with a trach. Any kid who is home with a trach, we want to make sure they have emergency equipment with them everywhere, even when they go to the grocery store, which means 2 spare trachs, the same size and a half size smaller in case they can't get the same size in, and we train the parents on how to put it in. They need suction catheters in case they get a mucus plug. That means they also have to have the suction machine, a portable machine with them, spare trach ties, and a bag valve mask in case they have to do some breaths. And here's a picture. And kids with trachs they need to play and act like normal kids. So how do we minimize psychosocial impact of having a chronic respiratory condition? Well, we really do want to support these kids' self-esteem, and we can do that through education, helping them to know what's going on and understand. Allow the school-age kid to do as much as they can of their own care. Promote the family's coping. See where they cope well and where they need some help, and get them that help to cope through all of this. And then be culturally sensitive as we're providing education and interventions.